we good? All right, try it again. It's 8:30. We'll call this February Central District Health Board meeting to order. I've asked Corey to take a silent roll call. We have quorum. We might be joined by a couple of others as we go along here, but for now, is without objection, we'll approve the agenda as presented. Any objection? All right, agenda is approved. Without objection or correction, we'll approve the minutes from last meeting as presented. Any comment? Seeing none, the minutes from last month are approved. All right, are there any public comments? It doesn't look like there are any people's in here. Going once, twice, seeing none. We are now on to Laurel and the review of the financial report. Laurel, take it away.
Dr. First. Dustin will be getting our budget to actual report through the end of January pulled up. Thank you. So this report is 58% of the way through the fiscal year. The first thing I'd like to draw your attention to is that for our revenues, we're at 68% of our planned amount total, and for our expenditures, we're at 59% of where we plan to be. So expenditures are almost exactly where we'd like to be, within 1 percentage point, which I think we don't typically see. So that's really good. And the primary reason that our revenues are above where we plan to be is that we did record the receipt of the second Ada County payment, which puts us at 93% of what we're planning to get for the whole year for our county funding. We actually got that the first week in February, but we went ahead and reflected it in this January report since it applies to the whole fiscal year. So looking at our fees, that's another thing I wanted to point out. We are at 66% of where we plan to be for fees. So you'll notice when we move on to the budget revision that we've increased what we expect to receive in our fee revenue. Our contracts are pretty close to planned amounts. Other revenues also very close to where we plan to be. And then looking a little closer at our expenditures, again, personnel is right on where we plan to be and looking pretty consistent across the divisions. Our operating and capital continue to be above where we plan to be. Operating is mostly due to just increased costs and a few things that we didn't plan for, like IT costs. And then the capital expenditures, we had anticipated that most of our capital costs would be covered through our special projects designations, the projects that we planned in there. But with capital projects, you don't always plan for everything that comes up. So there has been additional spending in capital. We've seen that throughout the fiscal year, and we're adjusting for that in the budget revision also. The total amount that we spent in capital, the $180,000, is still not an exorbitant amount compared to what we typically spend. It's just more than what we had planned to spend in capital for the whole year, thinking that it would mostly be covered by those special projects. Our trustee and benefits expenditures is a little bit behind our planned amounts, and we'll also be adjusting that a little bit downwards in our budget revision. So overall, in a good financial position. As we move on to page 2, we'll look at it across the past 2 fiscal years. And this is where you can really see that we've had an increase in fee revenue across our programs. There are really not any areas other than our reproductive health where we're seeing a slight decrease in our fee revenue, but everything else is increasing, and some significantly. So we're where we've normally been at 1.1 million and close to $1 million. We're almost at 1.5 million for our fee revenue this year. So that's nice to see and be causing a little bit of a request of an increase in budget based largely on that increase in fee revenue. Our contract amount is below where we were the past couple years, but morning, we planned for that as well, knowing that some of our contracts were either stopping or decreasing in this fiscal year. So although we see the decrease, it was a planned decrease. As we talked about, our fee revenue is up, contract down when you look at that last little box in the left column. And then for personnel costs, when we look at it this way by how many pay periods we're through, we're showing that we're a little bit under in personnel costs. Again, operating is over, as well as capital outlay, and then the trustee and benefits is under where we plan to be. Moving on to the third page, again, you'll see that the Ada County payment is reflected in our cash balance. So our cash balance is higher than it's been so far this fiscal year because of that, with a balance of about 12.6 million. Of course, most of that's designated. Our special projects, I'd like to draw attention to a few of those, not everyone as we have the last couple months. Our capital improvement office expansion. So that project will be a change in the family clinic services lobby and an expansion of where we have our community health workers sitting in our community closet. We've just got the drawings back on that. We haven't gone out to bid for it yet, but we will be doing that, putting it out to bid before the end of the fiscal year. Not sure how much of that will spend down before the end of the fiscal year, but the project will be started and you should see some reflection in that before the fiscal year ends. The other couple things that I like to draw attention to are the retention incentives, which cost more than we planned this year, based on better retention. So we have more people that have moved up into the categories where they're getting the bigger retention incentives. So that's caused it to be more expensive than what we planned for. So you see that reflected there. Those were paid out for the first paycheck in January, and so much appreciation from the staff that we've been able to do that and have your support for that. So thank you for that. Next on the list is the capital improvement continued project of the McCall facility and the Armstrong bathroom. I showed you some pictures of the upgrades to the McCall facility last time. We are doing a small phase 2 of that where we're replacing the flooring in the exam rooms, the areas that we didn't do new carpet in. So the exam rooms will be getting new flooring and transitioning into office space since we're no longer offering clinic services there. And there are a few other final upgrades there that we'll be doing, and that will be complete. And then the Armstrong bathroom, that is currently, as of today, out to bid. It's live on our website. It's been in the newspaper the last 2 weeks. This is the first time for a project like this that we followed the county procedures of putting it in the newspaper and sending it to as wide a variety of vendors as we can, rather than just announcing it on our website and sending it to a smaller list of vendors that we normally work with. So I think it's been about 9 months to a year that the board approved a new purchasing policy for us that allows us to mimic the county procedures rather than the state procedures, or gives us a leeway to use whichever we need to in some cases. But this is the first big project that we're trying this way. So we're hoping to get more than either 1 or 2 bids, which is what happened the last 2 times we put it out to bid. And this will just give us that better variety to be able to pick from different vendors and get the right fit for the job and not just see only one bid coming in and kind of not having anything to weight it against.
So how long is it? 2 weeks it's been in the papers?
Yes. So the requirement is 2 weeks before it goes out to bid, you announce that it will be, then 1 week again, and then it's live on the website, and we send it out again to the list of vendors that we have. And then we'll do 2 options for a live walkthrough of the job so they can see the job itself. And then there's another period where they have any questions that they have, they can submit the questions to our purchasing specialist. Then we answer them back publicly. And then after that, there's a date that the bids are due. So the entire period ends up being quite extended, and that's what the purchasing policy dictates. So we're following it, and by April, I think, is when the final date is for the bid to close, and we make the decision based on lowest cost vendor. Okay, and then the last seeing there, the Excella continuation, our environmental health system. Curtis has been working with them to find out when we'll be getting our final invoices from them. We have not gone live yet with that, but the project is wrapping up. And so we should be getting some additional invoices that'll be reflected before the end of this fiscal year as well. So still showing a very low rate of spend down, but we do anticipate additional spending and hopefully close to that amount before the end of the fiscal year. That leaves us with our total reserve fund designations of just over 7 million, the restricted funds of almost 4 million, and cash balance undesignated, unrestricted of about 1.5 million back into the positive there with that receipt of the Ada County funds.
Mr. Chair, Laurel, going back to page 2, up here, do you refresh me on is the central care number, is that because of the Ada County payment? That's up so much. What's
that is just fee revenue. That's purely fee revenue there.
Okay. So yeah, I see that's a big difference. And also our reproductive numbers are down. And are we seeing less activity in our reproductive clinic?
Sorry, there you go, Mr. Chair. So during a period of time, so we had lost the Title X funding and we had applied for Title V funding, which was for reproductive health. Originally, we did not get that Title V funding, so we started coding our reproductive health services differently. So they weren't showing up that as reproductive health. So my best guess is that the numbers for reproductive health for part of the year is reflected in central care.
Oh, okay. Okay. Okay, thank you.
So it does look like the ICD coding.
It's based the way, it's one of the modifiers that we put in there for just for reporting purposes, so that we can see in there more so than the ICD-10.
And also under administration, that difference of, there's a big difference there. Is that FTEs?
That is our contract revenue. So that is the public health infrastructure grant. We recorded that all in the administration division, although the FTEs that charge to it are divided among the divisions.
Oh, okay. Thank you.
Any further question, comments on that part of it? Well, and I think we've got Laurel part 2.
Dr. Birch? This is an action item, so I'll go through it and then request a vote. So the first page of the proposed budget revision is a summary of the revision that we're requesting. Overall, we're looking at a budget increase of $571,000, which is about 3.6% increase in the budget. So I'll talk a little bit more about that. We're requesting a small increase in personnel, just under 2%, 12.7% increase in operating. And that's, again, what we just talked about when we looked at budget to actual costs of run higher. So we're requesting an increase there. For capital, we are requesting an increase of $131,000 to cover mostly the costs that we've already spent this year and that big overage that we were showing in the budget to actual report. For trustee benefits, we're requesting a slight decrease in the budget there. We had planned initially at the onset of the year to spend more than we are going to, so we're requesting a decrease there. So that summarizes the expenditure changes that we're requesting. And then for our revenue, so that it balances and matches, of course, there's no change in county funds requested. We are anticipating an increase in our contract funds of 3.5%. And then the other thing we'd like to reflect accurately in the budget is our increased fee revenue that we just looked at on the budget to action as well. It looks like it'll be about 8.3% above where we thought we were going to be at the beginning of the year. We're looking at a small change in our other revenue, also a small change increase in our interest revenue. And then for our reserve funds for those special projects, that we looked at, most recently on the budget to actual, we still, you saw on that page, we had only spent 650,000 of the designated 1.7 million. So that's page 3 of the budget to actual. So some of that 188,000 we're requesting to move from special projects into our general budget. We can look at that another way on page 2 of the budget revision. See it broken down across divisions. So for support services, we're seeing an increase of 82,000, community environmental health, decrease in revenue for family and clinic services, an increase for a total increase in our revenue of 377,800 with a reserve fund change, moving the special projects, some of the special projects money into our general revenue budget for a total positive change of 571,300. And then our expenditures, again, trustee benefits going down, a little bit of a decrease in community environmental health. And that's for under trustee benefits. So total increase there in our expenditures of 571,000 as well. Our total budget will be going from where we started at 15.9 million to 16.5 million, which is an increase of 3.6%. I think the two biggest changes that we're reflecting in this are that increase in fee revenue and then moving some of that unspent special project money back into the general budget. So it's not actually more, that 188,000 is just moving where it was from special projects into the general budget categories where we need to spend from.
So the community environmental, is that just the inspections going down? Inspections, is that category?
So for community environmental health, fee revenue, it has been going up so far this year. So I don't know if the decrease is just because we've already received most of that in so far this year, Curtis, and we aren't anticipating as much throughout the remainder of the fiscal year. Do you know why
Sure. Yeah, so we've already received the bulk of our food fees for the fiscal year, and so we don't anticipate getting a lot more through the remainder of the fiscal year, and so we've decreased our projection on that slightly. Thank you.
So the bottom line is we've got a increased revenue by the 377,000.
correct?
And the expenses are up 571. I'm reading.
So that is correct. However, there's also the change of moving the special projects fund that's been designated for those special projects into the general budget. So that we were planning to spend already, we're just moving where we plan to spend it from the special project categories into the general budget. There are a couple examples that I have of that. So if you go back to page 3 of the cash balance statement, the second line item under the special project carryover designation is IT equipment support. So some of the things we've had to spend money on the IT cost this year is like a change in our annual Microsoft licenses that cost $30,000 or $40,000. It doesn't fit in this category. It fits in IT operating, so we don't want to spend it from here when it really fits in the general budget. So to keep the integrity of the special projects, as we stated at the beginning of the fiscal year, we want to move that money into the general budget and spend it in the general categories, not where we've told you we're spending it on this specific thing and then it's something that doesn't fit exactly in that definition. Another thing there you can see on the vehicle line further down, the board had allowed 100,000 for vehicles. We purchased those. We have got 3 vehicles for 5,000. So that 15,000, we're moving back into the operating budget. We'd like to move back into the operating budget as well. So it's things like that where for the special projects, the cost either didn't fit quite into those categories, or there's extra that we don't plan to spend this fiscal year. So we'd like to move that into our general operating budget.
Other questions? Earl?
This really isn't a question, but it's a thought of what I'm hearing out of the legislature. We're gonna have to rein in.
So how do you think that comment
I,
reflects
like I say,
what we're considering doing?
I'm just kind of looking at what we've got right here, you know, is pretty black and white, but how that affects what can happen in the future. Russ, you look like you have a comment.
I have one as well. As I was putting my notes together yesterday, I was thinking about that too. You know, we're hearing 3% cut kind of thrown around a lot, and I'm saying 3.6% increase. I think what I'd like the board to take into consideration is that we have an increased revenue coming in too. I know our expenditures have gone up as well. However, we're getting in more in fees in than we have for any fiscal year since I've been here, which reflects the work that we're doing in the community. So while that budget is going up, of course, our expenditures have to go up to match it when we're doing more work to get those fees in. We're paying for staff to do the work and the other costs that go along with it. So while it looks like we're saying this is a 3% budget increase, it's because we're getting additional fee revenue in and then moving some money that the board already designated to be spent in special projects into the general budget. So I realize that the number is still an increase, but I think it reflects more the work that we're doing than saying, hey, things are just costing more. We're requesting more money from you or from contracts or anything like that. We're getting more money in from the work that we're doing.
And as I'm driving in this morning, I'm hearing about all the cuts for next year. So we need to keep this in mind.
Mhm.
Yeah.
As long as we're not spending more than we have.
So to distill it down, I understand what you're saying about recategorizing,
Yeah.
but with the increase in revenue, how much out, notwithstanding the shuffling of the categories,
Yeah.
how much more is going out the door accounting for the increased revenues? How much more than the increase overall?
Well, I think the way that I think of it is every time, when we're putting the budget together or doing the budget revision, we make sure that we plan for our expenditures and revenues to match. So don't know what we consider we look at first. Do we put the cost of everything together and then say what fees and contracts are going to be coming in to make that match up? Or do we start at the other point and say, here's everything we plan to get in. Now, how are we going to have our staff and operating capital expenditures match that? It's a balancing game. So when we know we're getting the extra fee revenue in, we plan our staff accordingly to match that. The special projects money, I think, is kind of moved because it's moving from one area to another. In this case, the increase in expenditures matches the increase in revenue.
So this does not require going into reserve
Does
funds of any
No.
kind or.
Just the special project designation, that's it.
Jane and and Russ will remember the years not so far back when we had no county contributions from some counties and it looked rather bleak. So I guess that's, my memory serves me there.
All right. Any other questions? Okay, so this is an action item that's before us. Is there also a motion?
I'll move to approve. the budget revision reserve designation.
We have a motion and a second. Is there any discussion on the motion? Any discussion? Seeing none, then all in favor of the motion to adopt this budget revision as presented, signify by saying aye. 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 Any opposed?
Aye.
She's there. Any opposed? Right, motion carries. Right. Very good. Thank you, Laurel. Then we are now moving on to emergency and non-emergency succession plan policy with Russ. The reins on that.
Okay, so we have, we put this in place a number of years ago, actually in 2014, so more than 10 years ago. And what this really serves as is a guide for the board to understand very directly if I am unable to continue to do my job on a short-term, temporary, long-term, probably temporary, and then a permanent unplanned absence. And then it also describes our overall goals as far as succession planning within the agency so that people are prepared to move up into higher level leadership positions. Nothing has changed. This is just a review. We reviewed it last February, and the policy itself talks about doing this at a time when we do the board elections, which happens in May, but we did it in February, so it didn't necessarily make sense to re-sign it, redo it. So we'll review it today with your approval, and then the next time it'll be reviewed will be May of 2027 when you do board elections to get back on track with what the policy says. So the order of succession as far as director position for those various scenarios that I just described will be based on longevity. So Laurel would move into that role, and she wasn't able to do it, Curtis, and then Beth, based on the time they've been with the agency. So this is just a review. There's no changes, but this is the document that I think you would find very valuable should we run into that situation. You won't be left wondering how it'll work and how the acting roles will be compensated during that absence. So just looking, really an update, but looking for your approval, and then if it does get approved, then Dr. Birch will sign it, I'll sign it. And the division administrators have already signed acknowledging their roles. That's on the third page of the document. Then it'll become officially updated with new signatures and a new date.
Great. Any questions for Russ? Okay. This is also an action item, so this is before us.
I would move that we approve the emergency and non-emergency succession planning policy as presented.
All right, any discussion on the motion before us? Seeing none, then all in favor of adopting the plan as presented, signify by saying aye. Aye.
Aye.
Any opposed? All right, motion carries. All right, so cute. All right, we're moving on to our next agenda item, discussion about childhood immunization rates in our district. Dr. Jean. Jamie.
Mr. Chair. I don't know if I've
Dr. Cole, I don't think I've met you. I'm Dr. Jamie Butler Dawson. I'm the new EPI program manager. And I've been here about 6 months, but nice to meet you. So today we're going to talk about vaccines, and I'm going to present on the data that we have for Idaho and then the county level and the school level. And then Beth will talk about what we're doing at CDH and next steps. Next, please. So first, well, this is school age vaccination coverage. So this is the data I have. It's for the school age. And we won't be talking about the early, like infant childhood vaccination data. And again, this is Idaho and District 4. And just briefly, I want to talk about the vaccination schedule, just so we're on the same page. So the schools are required to submit immunization reports to IDHW, the state, every November. And then they have an aggregate count of the data, and it's for kindergarten, first grade, 7th grade, and 12th grade students. And the vaccines that are reported are for the early childhood vaccines. So kindergarten, we have MMR, which is like measles, mumps, and rubella, DTaP, polio, Hep B and A, and then chickenpox. And then there's the 12th and or 7th and 12th grade. So the boosters, the Tdap booster and the meningococcal vaccines. And then vaccination coverage just means the proportion vaccinated among all school age children that are eligible, and it's by grade. Next, please. So first we'll dive into just the Idaho data, and this is coming from CDC. So just the key message is that Idaho has the lowest vaccination coverage rate and the highest exemption rate in the US. So here on the right is from the CDC webpage, so it's showing all the states. You see Idaho is about 80% on average. This is the MMR kindergarten vaccination coverage. And then I just broke out the numbers, the percentages on the left. So here we have US in the white and then Idaho in the yellow. So hovering around 78%, and then Hep A is a little higher because that's given at birth. And then exemption rates, usually it's categorized as medical exemption or non-medical. So altogether, the US average is 3.6%, and then Idaho is 15.4%. So that's why we're the highest in the US. And then for non-medical, it's the largest proportion for the all. So it's 3.4% and then 15.1%. So medical is just like 0.3% for Idaho, the exemption. Next, please. And then looking at just trends across time, this is still Idaho here, and Idaho is the lower line. So starting in 2011, going all the way to the 2024-2025 school year. And this is MMR vaccination for kindergartens in Idaho. We've always been lower than the national average, but you see after COVID, we have a steeper decline showing. Next, please. And then this is the Idaho versus the US exemption trends. So we were higher, in 2011, we're higher than the national average for any exemption. And then after COVID again, we have a very sharp increase starting about 2019. We're all the way up to 15% for any exemption and non-medical exemption. And then the medicals hovering around 0.3%. Any questions so far?
I do have a question. Can you explain the difference between any exemption and non-medical exemption? What's the difference in the two?
Well, traditionally it's, so if you go to a medical doctor and they say, okay, your child is compromised and can't get all these vaccinations, we're going to do an exemption. And so you get the doctor's signature and you bring it to the school and say, for medical reasons, my child cannot get the exemption. And then the non-medicals, religious exemptions are personal, like your personal beliefs. So those are those two categories. Okay, next. Okay, so now we're going to dive into the District 4 county level vaccination data, and this is coming from IDHW. I got these numbers. And the key message here is that coverage has declined in all 4 counties from 2018 to 2024, and non-medical exemptions seem to be driving the decline. Next, please. So we have the 4 counties. So we have Ada and Boise up top, and then Elmore and Valley. And these are the 3 grades that I'm showing right now. So kindergarten is in blue, first grade's in yellow, and 7th grade is in purple. And then we have this is overall average adequacy rate on the y-axis, and then the x-axis is showing the year, so 2018 all the way to 2024. So you're seeing in all 4 counties and all the grades a decline across the years in vaccination coverage. I'm not sure what's happening in Valley. It's a little bit not the trend, it's going up and down, but I mean, it could just be a data collection or data error. Any questions here? Okay, keep going, please, Tori, thanks. And then I'm just kind of doing a micro level here of the vaccination coverage trends by county. We have Ada County in red. Oh, uh-oh. I didn't like that slide.
Talk to.
There it is.
Okay.
We have Boise in green on the bottom, Elmore in, I guess, turquoise, and Valley in purple. So it's again, the x-axis is 2018 to 2024, and MMR coverage percentage on the y-axis. So just giving you an overview. So we have the Healthy People 2030 is a goal set. So that's your gold standard is 95% to have herd immunity. And then the national average is that blue dotted line. It's at 92.5%, and then the Idaho average is 78.5. So it's just showing the different trends across the years for all 4 counties. Any questions? Next, please. And here we have the 2024 county exemption rates. So it's ranging from 7% at Elmore and then 25% for Boise. And I just have the national average here at 3.6 for exemption rates. And this is any exemption rate we're covering. And then Idaho state average is 15.4. The district average is 14%. Any questions here? Okay. Okay, Corey. Okay, and now we're drilling down into the school level data. The key message here is that low vaccination and high exemption cluster in the same schools, giving CDH a roadmap for targeted interventions. Next, please. This is my favorite figure, even though it's not showing great data. But so this is for Ada County, and this is showing that schools with the lowest coverage equal the highest exemption rate. So each bar is a school in Ada County, and this is elementary school. So the green means they're doing really well. So they're 95% or greater. And then the yellow is moderate risk of outbreak, orange, high risk, and then very high risk are the red at the bottom. And the black diamonds are the exemption rate percentages at those schools.
Mr. Chair, are all schools covered, including private, public, charter, or is this strictly public schools?
You know, I did look into that yesterday and I couldn't find that information. So this is 107 schools in Ada County. I think I have a slide at the end for extra, but I think there was 7 schools in Elmore and 4 in Boise. So I'm not sure if it's charter or private and what the requirements are for that. Any questions? Okay, next, please. And this is just a map showing the schools that were covered. For Ada, you know, we have 107, it's hard to read, but it's just, the point is that outbreaks concentrate in these pockets of under immunized individuals like schools or communities. And so we're seeing that here. And it's the same color range as green is doing really well. You know, orange is that moderate risk of an outbreak. Orange is high risk and red is that very high risk. Next slide, please. Do you have a question?
I do have a question on that one. So the reported risk is based on the lack of immunization.
Right, like what's their percentage? Yeah.
Okay. So in the bigger picture, given the lower vaccination rates, for instance, in the state, how much higher is our incidence of these, you know, the measles, the mumps, rubella, you know, compared to what is the sickness rate in Idaho compared to other states, given our
I don't know if we know that what our risk could be because of the vaccination coverage. It's a high risk because the goal is that 95%. So it's just basing it off that threshold of 95% herd immunity or herd immunity. Sorry. So I don't know, like the incidence, so measles right now is happening across the US. We've had 21 cases in Idaho. It's just, it's a plane ride away is the thing, so if someone comes, they've been traveling, they don't have symptoms yet, but they've been exposed, it could blow up at a school or like a basketball event. Like in Utah, there was a wrestling event and one of the kids who was wrestling ended up having measles and exposed, everyone there.
Yeah.
So it's just that potential, I think is it's the potential, like if the disease shows up and then, the right symptoms and it's,
But at this point, our historic higher level
Oh, I
of
see, but yeah.
exemptions hasn't necessarily translated into an ongoing higher incidence of disease.
Well, that's this slide right here is just showing, and this is, like a suggestion. It's not like a causal thing, but looking at DTaP coverage in Ada County, it has declined. So on the left figure, it's showing the DTaP vaccination coverage in Ada County among kindergarten students from 2018 to 2024. It's gone down significantly. And then here I have pertussis cases have gone up significantly, especially, 2024 and 2025, obviously still in 2026, but that's just, showing like this is an issue already. It's here. We're seeing a huge surge of pertussis cases. We haven't seen measles in our county yet, but it was next door in Canyon County. There were 5 cases and, that's terrifying. It could just blow up.
From a medical point of view on the pertussis cases, because pertussis the vaccine doesn't stop one from getting nor shedding pertussis itself. In those case clusters in 24 and 25, do they go in and look at vaccinated versus unvaccinated?
So these are reported pertussis cases, right? So that, we had a lab confirmed report. These are probably people that have the more severe symptoms.
Right.
But we don't have that information. But yeah, that's a good question. And I wanted to just add that District 4 has been in a continuous pertussis outbreak since January 2024. So we haven't declared the end of the outbreak, which is in 28 days, but no cases.
But overall, 26 is trending downward based on those orders. For the quarter this year.
For the quarter, yeah.
For the quarter, we're statistically downward. It's trending right.
Yeah. It's hard to predict these. Yeah. Next slide, please. Just some key takeaways. So Idaho has the lowest vaccination coverage. District 4 vaccination rates are decreasing. Coverage varies widely by county, as we saw. Increasing non-medical exemptions are increasing. And then under immunized pockets of risk for disease outbreaks. And there's a need for public health action.
Thanks, Jamie. Next slide, Dustin, please. So I'm going to talk a bit about what are we doing within our clinic services and what have we been seeing specifically with what we are doing. Next slide. So we were able to gather data for the calendar years 2019 through 2025. And as you can see, we had a sharp decline of immunizations given from 2019 onward. We were close to 8,000 in 2019, and then last calendar year, just under 4,000. Some things that have happened during that time period, at the end of fiscal year, I believe 24, we ended our community immunization and outreach team due to changes in funding. And that team was specifically going out into the community and providing immunizations at a variety of places. They had a team, I believe, of 4 or 5 people that was their dedicated time. That team was around between 21 and 24. So that doesn't just describe the impact of what was going on in 2019 when we were able to provide so many more immunizations. So as you can see, 2025 has been our lowest year, and that's given us some information that we need to start looking at what are we doing. So next slide, please. So with that, we've really focused on one of our strategic plan goals for the next 3 years is to be able to develop and implement a strategy around increasing immunizations within our district. We're right at the beginning of that process. We had a kickoff meeting in early January where we had a cross-division collaboration around what can we do to increase those rates. It was a great opportunity to really brainstorm and hear from people from a variety of different perspectives of where are we doing well, and where do we have room to keep growing and ideas on how to do that. One of the key takeaways for me was that our clinic and WIC team hadn't been talking about this at all. WIC, one of their training opportunities that they do every year is around immunizations and being able to help support families in WIC if they have questions around that. But we weren't collaborating across the two teams. So that's going to be one of our first things that we're going to be looking at is how do we increase that cross-program collaboration so that we can continue to help families have immunizations available, know that we're here for them if that's what they would like. The other things that we're looking at is how do we continue to make sure that we are across our whole district providing those offsite clinics. Currently, we're in all districts, but some in a more limited capacity. We go up to Valley County every 3 months, and we're at the school there. We're in Boise County as well as Elmore, but we want to be able to make sure our reach is expanding so that we can do those offsite clinics. One of the beauties of our offsite clinics is most of them are going to be in schools. So it's removing that barrier from families that they need to take off work, that they can just have that done in school. We're able to look up an iris, see what is missing. Parents provide consent for which ones they can receive, and then we're able to do that. And then when we come back, we can do follow-ups as needed. So during this time, as we're looking at the strategic plan and our first steps, is one that across program collaboration. The second one is identifying. So our community immunization outreach team dissolved. We still have a team that's out in the communities. What can we do? How can we maximize their impact? And then what do we need to continue to grow that? And developing, if that is a staffing plan, what does that look like, as well as proposal how to support that financially. So that's where we're going. And I'm really excited over these next few years to be able to talk to you about our progress as we begin to implement these plans and see how this has an impact within our district. Questions for me?
Beth, do you currently have like WIC clinics going on in Idaho City, Horseshoe Bend, and Cascade? Okay, so that interaction, that lab is happening. Yes.
Any more questions? All right. Well, very good. Thank you, lady. All right, next on our agenda, Curtis is up. Environmental health. Curtis.
Hey, Mr. Chair. All right, Dustin, we should have a presentation ready to go. You should have a handout as well in your package, so we can look at those. I just wanted to start out by giving just a brief overview of some of the work the division's done over the last calendar year, 2025. Making sure that you guys are aware of how funds are being spent, what staff are engaged in, and some of the great work that they've been able to accomplish. All right, next slide, Dustin. So I'll be covering our food safety and environmental health groups, our land team and our facilities team, as well as our communicable disease team, health policy and promotion, and our emergency preparedness team. So first up is environmental health. Just some figures here for you to look at and see. And again, this is referring to calendar year 2025, so not necessarily fiscal year, but calendar year. Starting off with food safety, we're looking at around 4,500 food establishments within our 4-county district, and we're conducting nearly 5,000 inspections on those. So that includes everything from the annual inspection that we're conducting as required by regulations, and also includes any of the additional inspections that are related to complaints, follow-ups, or anything like that that we need to continue to carry out. Within those inspections, our inspectors are looking for a number of criteria and investigating and inspecting and ensuring compliance with all the regulations as reported in the Idaho Food Code, as well as providing educational opportunities to those operators for how to better handle and manage food preparation, storage, and service so that we can ensure people have the best experience when utilizing those services without getting sick. In our childcare safety places, we have nearly 400 establishments throughout the 4 counties, and again, with over 400 inspections annually. That's the annual inspections as required by regulations, complaints, and any follow-ups that are required to continue to happen throughout the year. And then our land team, they've got quite a workload that they engage in. We had over 700 applications for septic systems that we had received in calendar year 2025, which resulted in us writing and approving over 500 permits for septic systems in the district. And that's a wide variety across the different counties. And I can break that down for you at a different meeting or send you that information. But each of the counties have a large number of different types of permits that they are receiving. In addition to that, the team has reviewed and approved 155 subdivisions. That's land development that comes through our office to ensure that we are appropriately reviewing and lifting the sanitary restrictions on land as it's being developed, and ensuring that that land has sanitary options for sewage disposal, whether that's through municipal sewage supplies or an approved septic system. And that includes 5,800 buildable lots that have been reviewed and approved. So it's a large number of reviews. It's a lot of work that happens. Brent and his team have done a fantastic job keeping up with all of that and developing and implementing some pretty efficient processes to make that happen. As well as Natasha's team for, clearly over 5,000 inspections a year that they're doing and getting all that work done, along with the training and education that goes along with that. Natasha's team also held over 20 Serve Safe classes throughout the year, where they certified over 200 individuals in safe food management. And so that's another aspect of their work that they've done. Right. Next slide, Dustin. Yes.
Curious, what are private drinking water systems?
Private drinking water systems. So yeah, we have municipal water supply systems, which supply most cities and people within city limits. We also have systems, and Brent, you may need to help me on the details here, but they are typically designed for systems that are like 20 something or less users.
25 or more, 60, Mr. Chair.
Yeah.
25 or more persons that use the system more than 60 days out of the year.
Yeah.
It's like private well.
So a private well that feeds more than one household, basically. So anytime you get to that threshold of a single well that provides at least 25 connections or at least 60 days out of the year, it's considered a private drinking water system. And we inspect those and ensure that they are compliant with the regulations and that they are producing safe and usable water that is suitable for human consumption. Yeah.
Now I know. Thanks.
Great. Moving on to some of our other programs, public health preparedness. One of the things that I wanted to highlight with this team, this is a small but quite mighty team. They do a lot of work behind the scenes that isn't nearly as countable as, say, the number of inspections that are done. So one of the things that I wanted to highlight is we recently held a statewide public health preparedness conference here in our Huckleberry conference rooms. We had representatives from all 7 health districts here. We had representatives from local tribes, as well as our state counterparts from the Department of Health and Welfare present. And we have held a number of trainings and exercise and developed a plan for just about anything that you can imagine. So if there's a potential public health threat or problem ranging from earthquakes to outbreaks to summertime fires to anything else you can think of, we probably have a plan for it and have trained about it and done an exercise on how to respond to it. And that's because this team does all that work and the legwork of developing those plans, creating those trainings, and helping us exercise and work through those different opportunities to learn and plan for how we want to respond.
So do you coordinate with emergency services?
We do. We have very clear partnerships with all 4 county emergency coordinators, as well as with the state and federal. So we have access to things like the national stockpile, any of the state and local emergency response coordinators we're very much in tune with. We had an example not too long ago where in Boise County and Idaho City, because of some precipitation and flooding that had occurred, had contaminated their city drinking water, the potable water supply. And so in connection with DEQ, state officials, their county emergency manager, the team was able to come together and pool resources and work together to resolve that issue. We had a plan in place. We had trained on how to respond, and everybody involved knew their role and what to do, and it was quickly resolved. So a great team that does a lot of work, again, behind the scenes with less countable widgets to put on a slide and show you guys, but nonetheless, something that the team works very hard at doing. Just to follow up on that, at this preparedness conference, we actually did a tabletop exercise with the group regarding a measles outbreak, and they had a fictional situation where a participant at I believe it was a basketball conference game or something, a tournament game, came and exposed a large group of people to measles. That was the fictitious situation that we were looking at and how we would respond and what we would do. Lo and behold, as Dr. Butler-Dawson reported earlier, that actually occurred in the state of Utah with a wrestling tournament. And so a lot of these situations that we plan for are things that are actually occurring in other parts of the country, and we're trying to learn from those, incorporate that information into our planning, and then build trainings and exercises around that. So. Right. The other part on this slide is our communicable disease control team. This is our epidemiology team. You can see this is again, not a large team. I think we've got 4 staff members that are epidemiologists doing this work, and they, over the last year of 2025, conducted case investigations for 6,000 cases of unique diseases that were identified, and those are things that are reported to the health district and either confirmed by lab, or then we do some kind of investigation to determine source and how things were transmitted and what we could do to interrupt that transmission and how we stop that disease from progressing throughout the population. Those 6,000 cases resulted in right around 61 outbreaks being declared. And as you saw in the last presentation, one of those outbreaks being the continuous pertussis outbreak that we are currently dealing with. And in the chart above, you can see that pertussis is in our top 10 most frequent diseases that we are currently investigating and continue to work with. Questions on that slide? All right, next slide, Dustin. Okay, health policy and promotion. This is one of our larger teams in the division. They do a wide variety of different things. So this is the team that works with lots of groups of people, from school-age children to the senior population and everything in between, and does everything from tobacco prevention to suicide awareness and nutrition education. If there's a way to improve someone's healthy lifestyle, this is the team that tries to accomplish that. So some of the events that they've accomplished over the last year, health screenings. We held 62 unique events where we screened over 300 participants for cardiovascular disease. That was checking for things like A1C, blood pressure, cholesterol, weight management, and then referring them to family physicians or to a primary care physician as needed if their screening indicated so, or they needed assistance with that. You can see that picture in the lower right corner there. That's actually Alex, one of our staff members in Elmore County, in a rural setting with a folding table, conducting health screenings for a group of individuals who are interested in doing that. So he's out and about nearly every day conducting that type of work and helping people ensure that they have access to the healthcare and the screenings that are needed to help keep them healthy. The picture above that is our giant mega brain. It's the inflatable brain that we take around to the schools. It's highly popular with the students. We've got two versions of it. One is the big walkthrough version that you see there, and then there's one that's a little bit smaller that's more of a classroom model. And it lights up and it's got lots of cool things and features about it. And we've got great staff that will teach students about the effects of substance use on the brain and different things like that, as well as mental health and some of the behavioral health things that we want to address with them and talk to them about. Our Cooking Matters, we've held 8 unique events where we've taught over 121 people to about nutrition and healthy cooking and the way to improve their health and lifestyle through good food choices and cooking options. So our health education, we've backfilled some positions and increased our staff slightly with some new positions. So we have a nutrition coordinator, which is a position that was approved for funding, and somebody who is going to be working throughout the district to help coordinate and increase our ability to teach, train, and make aware nutritious and eating habits. And so that's something that we're very excited about, as well as a suicide prevention coordinator who is working with a wide variety of populations on the prevention and awareness of suicide throughout the district. Fit and fall proof, we have a number of locations throughout the 4 counties serving over 4,500 individuals, and that is fit and fall proof. Those are classes specifically designed for the senior population to help keep them active, moving, maintain mobility, improve balance, improve strength, and keep them active and healthy. We are holding routine trainings here at our office where we train our volunteer coordinators for all of those sites and helping them become educated in that, and then helping to assist them run those different locations. So, and then one of the exciting things that we've got going on in Valley County specifically with our V Corp is we recently received a $400,000 per year grant from HRSA, which is part of the federal government. It's for 3 years, and it's specifically to help develop a behavioral health career pathway within Valley County. So that helps youth discover and have a pathway into the behavioral health career field, as well as better understand behavioral health options to help keep behavioral health in line. So next slide. Those are all the programs in the division. So happy to answer any questions you guys have, some of the highlights and things we've been doing over the last year, and happy to respond to any questions.
Mr. Chair, and Curtis, this is probably for Brent. Brent, is Mayfield Springs all septic systems, or do they have a community?
They have a treatment plant there.
They do have a treatment
Yes, they
plant.
do.
Good, good. So,
Bring the cool brain to the next meeting.
You bet. We can have a setup in here. You can put the big one outside. We've had it outside before, so that'd be fun to do, and put the little one in here.
I'm familiar with a guy named Dr. Daniel Amen, and he does a lot of work on brain injury, and he's got some pretty incredible posters on brain on marijuana, brain after 2 years of huffing. And he's got some really, like I said, really good sources. And I have some of his posters in my office. And it really delineates what happens to brain function when we start polluting it with different chemicals. And I really like that idea of sharing that.
Yeah, there's a lot of great resources out there, and we've got great staff that are very knowledgeable in that and access a lot of that material and then share that. And we use our inflatable brain all over the place and in just about every school district, and it's highly successful.
Any other questions, comments for Curtis?
Just gonna say, that's amazing to be responsible for all that. You realize all that you're doing?
Mr. Chair, it is a lot, and it's a wide variety, which is what I love about it. Is it's so diverse, and the ability to affect so many different groups of people and such vast populations throughout a unique area of the country, from the very urban downtown Boise area to the very most rural parts of Boise and Valley County, and be able to effectively improve the health and the quality of life of so many different people. I think it's an amazing opportunity for everybody in the division and something that I'm very proud to be part of.
Just a comment on the fit and fall. Those seniors get out and it does so much for their mental health. I mean, they have a ball. They're just swinging and line dancing and it's great. So.
Mr. Chair, in addition to the mega brain that we'll bring in, we'll also have Mike Rice, one of our health education specialists, come in here and lead us through a session of fit and fall proof. He often does that for some of our staff events, and it's just a blast. So
It is. It is.
he has a great time, and he's got the best jokes. So.
Anything else? Thank you, Curtis. You can stay. Next on the agenda is Betty Ann giving us an update from the Legislative Council.
Corey, we might need a box of tissues here.
Do we need a break beforehand or after?
Right now, or
Okay,
5 minutes? All right, let's roll.
let's go. Okay. Russ and I've been watching this for a long time. And Russ, thank you for nonstop meetings. We hope some productive things come out of them, but I will have to say, and this is just Betty Ann talking, this has been the most insane lunatic legislative session I've ever remembered.
That's a good summary.
Oh, okay, thank you, thank you. I didn't know if it was just me or, oh, okay. We meet every Tuesday during the legislative session unless there are no issues coming up that would affect us. And Mike Kane has been on all of those along with Russ, and they've been working tirelessly down with the legislature. Okay, I'm going to start with a few items here, and this is just a few. Kratom. Dr. Birch just gave us kind of a segue into brain and organ effects. Kratom is hallucinogenic derived from a Southeast Asian plant. Currently in the state of Idaho, it is available with no age restrictions. Your junior high kid can go to the convenience store across from the school and buy it. 19 states have outlawed it. And it just boggles my mind that as health districts, we are trying to hone this substance into an acceptable shade of gray to make it legal. I just can't believe it. The Coroners Association has come out unanimously in prohibiting this substance. They say when they do their autopsies, you open the body up, the organs are green.
yes.
I just can't believe we're even talking about, legitimizing this in any form. Comments?
I couldn't agree more. I lost a good friend who was addicted to it.
Right.
Lost him to suicide, but he was addicted to it.
Yeah.
And you could see the downslide the more he used it. And it is, yeah, I think those who are making legislative decisions on this should have to come see those bodies.
Yes. Well, like you pointed out, it is an accumulative thing.
It is.
And I can't believe as health people, we're involved in conversations.
And to that point, yeah, a lot of drugs, what individuals don't realize are fat soluble and accumulate and get stored in body fats, like the higher dose THCs that people are using in marijuana products these days, which lead to increased rates of psychosis. And kratom can do the same thing. And the higher concentration THCs can stay in the body for weeks, if not months on end. Same thing with kratom, and the reason you see it in the body is because it's fat soluble, and then it bioaccumulates. And again, some of the logical versus illogical decisions that are made aren't made by those who actually see what's happening.
So to think that our little kids could go and get addicted to this just escapes me. Just escapes me. The consumer foods bill, which maybe Russ wants to summarize, that one passed, and I can't remember the number of that one. We do have House Bill 1326, which is a property access by public health officials, and it would exempt law enforcement, but this comes into like daycare supervision type issues, correct? And also in this whole situation, we're talking about videoing kids while they're asleep, correct? And the legal issues there, which is actually another bill, but to me, they mesh. So you want to chime in on that, Russ?
Yeah, I'd be glad to talk about any of these. Okay,
Sure.
so the direct-to-consumer bills, there was one, it's House Bill 526 brought forward, and basically it's Curtis and team, Natasha's team that oversees this. Cottage food, by definition, were formerly known as, they were not really potentially hazardous foods, as time and temperature control for safety foods were always regulated. They weren't included in cottage food. Cottage food made in the home, sold direct to consumers through like farmers markets or online. But this bill is proposing to allow you to sell, like literally you could make fish sushi in your house and take it to a farmer's market and sell it direct to consumers. There's a labeling requirement that it was made in a non-approved facility, but since it's unregulated, who regulates the fact that they don't have signage or whatever? I mean, there's a number of concerns, but we had a $5,000 cap on the original bill, as long as the annual sales didn't exceed $5,000, but no mechanism to really determine, other than, I guess, you'd say, hey, you need a license, and it'd say, hey, we're under $5,000. And that's where the conversation presumably would end.
For one product or for that seller total, do you know?
That's, I would say it's not exactly clear. Probably you could debate it. It was a very short bill. It just says as long as the sales don't exceed $5,000, but they don't parse out per product per. Yeah, so it would be really that, and the points we made were that cap doesn't change the risk profile. You're going to be selling potentially hazardous food to consumers with a label to say it wasn't made in an approved facility. And what could happen is a lot more people that are doing this today, like we have reports of it. We go out and we say, hey, you can't sell tamales out of the back of your car, potentially hazardous food. You need to get a license. So it's already happening, but we can correct it when we learn of it. And this will just basically open that door wide across the state. So then another bill came along. It's Senate Bill 1283. And that's really interesting. It's a very long bill. And the House bill made it through the House and then Senate and went to the floor, and it was sent to the 14th order, which, as I understand, it's basically they can amend it at that point in time. But I think what really happened is 1283 was presented in Senate Ag Committee, and there is no cap. So you can sell time and temperature controlled foods. You can make them in your home, any amount, and sell direct to consumer through various outlets, including online. So that, to me, is even
Online in state, because
in state, correct. That's a good point. Yes, you can't sell outside of the state.
interstate commerce, yeah.
Yep. So that's a good point. And there's a number of things in this bill. So meat, obviously you can have problems with meat, making people sick, undercooked chicken. You don't cool foods fast enough, you take it to a market, there's just a whole host of issues. So this bill, you can sell up to 1,000 poultry. So you can sell as long as you're stay below that threshold. So there's no $5,000 cap on most temperature controlled foods, but you can't sell any more than 1,000 chickens in a year. I guess turkeys, I don't know what else would fall into that category. Sell fish, but not catfish. That's in the bill. And we could do investigation in public health if it's a confirmed foodborne illness. So the investigative process is to determine whether it's a foodborne illness, but until it's confirmed foodborne illness, I'm not sure who would do that. Presumably, public health would not be able to do an investigation. So,
Does it carve out public health anywhere in either of those bills?
so it says specifically the Department of Health and Welfare, and we have those authorities through Dr. Butler Dawson and her team. So as far as doing investigations, and Natasha's team, the food inspectors would always be involved or often involved in those investigations too. So it says specifically Department of Health and Welfare can't do an investigation unless it's confirmed.
That collided a little bit with the trespass bill that we passed 5 years ago.
Yeah,
It was,
So there's no way to inspect if there is an outbreak.
right.
oh,
Yeah, and I get it. It's, the commentary made was, like, we're actually trusting adults to make decisions for themselves. And it's like sort of making light of that. That's not the point. We have regulations in place to keep people from getting sick from foodborne illness. I even mentioned the milk. You probably saw that in the news, the raw milk outbreak that put 2 kids in the hospital, and they didn't have any questions for me. My 2 minutes of fame. And I sat down, and at least 3 of them talked about how they grew up on raw milk and et cetera, et cetera, et cetera. And it's like, the point here is people bought that in. We don't regulate it anyway. It's Department of Ag. Bought that from grocery stores and took it home, and it was a couple different outlets, and drank the milk, and 2 kids ended up with, I guess, what you call kidney failure, basically.
Yeah. Syndrome, HUS.
Was it E. coli that caused it?
Yes.
It was S-Tech. Yeah. coli.
So, and that was like the idea, well, the comment was made, well, we regulate it and you still have this happen, so therefore, why regulate it? And I'm like, well, thinking, I didn't say it. We regulate speed, but people still crash cars and people still speed. But if we don't regulate it at all, then what would that look like? But anyway, I don't know how that's going to work out. I think it's probably going to pass. It made it out of that committee unanimously. So, do you want me to talk about childcare, or do you want to?
go ahead. Yeah. On the videoing. Yeah.
So this bill is proposing, so there's ratios for childcare. So depending on the age of the child, you get assigned a number. Like 5 to 13 would be worth 0.48 points, I think, is what it is. And then as they get younger, you get the points are a lot bigger, so that you have 1 staff per 12 points. So this bill is proposing for like in-home childcare, if it's your own children, 5 to 13, they don't count as part of the ratio. So you could basically double the number of children you'd be responsible for that would be considered safe. And that would be okay. So, cross my mind, I guess, if you're not watching your own kids, maybe
Then you
that's
get more time to focus on something.
the other one. Yeah. So that's obviously of concern. The ratios are put in place for safety, and then the video, audio surveillance monitoring would allow the providers to, I guess, have it on a screen somewhere, but maybe an infant sleeping in another room. And the whole idea is like how could you ever tell if the infant's not breathing or, trying to rely on technology. So there's a whole host of issues with that. I don't know if it'll go anywhere, but
Yeah.
it's like, wow, just kind of dangerous. And since we regulate childcare, it's of high interest. And a child did die, I think in Caldwell this past year by suffocated. I don't know what the circumstances were in a childcare facility. So the risks are real.
I can't remember the number on this one, and this actually was proposed. And for those of us sitting in here in healthcare, it would have put us out of a job. Because this bill prohibited advising any of your patients about healthcare, recommending. Like I say, this is absolutely ludicrous, but it was arrest. Yeah. Absolutely.
A few others.
Yes, there are. Others. Okay. Anybody ever heard of West Nile? I know that my county was impacted the highest in the state in 2007 with West Nile deaths, and now there's a bill to do away with mosquito abatement programs. There is another version coming out, which we haven't seen yet, correct? But I think that the lobby in support of keeping the mosquito abatement is pretty strong. In my county, and of course, it's a vector disease, it literally wiped out a lot of our bird population. We didn't have any horses that succumbed to it, but we certainly had people that did. And like I say, the bird population was amazingly affected. So that one is still in play. Now, we beat this one up through the years a lot on parental permission to treat without parental consent 14 to 17-year-olds for STDs or to test. Wow, that was struck down primarily by one legislator from Idaho Falls that tried to, this is a language issue in this bill, and we're all familiar with the conflict of those two. But she tried to channel that language into that we would be doing gender reaffirming surgeries and that type of thing. So ultimately that failed. We got no place. Now, in addition, you want to think about this with our suicide lines and stuff that we just talked about. A kid can't call and talk to a person on that line without parental consent. Now, very often it's the parent that is the abuser. So where's that kid stuck? Pardon me, folks, maybe it's just me, but I couldn't believe this stuff. I just couldn't. I have an acquaintance in Mountain Home, and this is a tragic, tragic situation. Teenage girl impregnated repeatedly by her father. The mother would take her for abortions. She can't call that line because neither one of those parents is going to permit that conversation to occur. So as we look at our chlamydia numbers and stuff, they will probably keep climbing, or other STD numbers, but I feel so tragically sad for these kids. I don't know where we go from here. Yeah. Unbelievable to me. There is a House bill coming out from Lieutenant Governor, I believe, talking about the violation of state law. And as I got it this past Tuesday, it was kind of comes down to the main focus on this was Boise City's, the municipality display of flags, like the gay flag, the LGBTQ flags. And This is brand new. I don't know any more about it than what was mentioned Tuesday, Russ. Do you?
So,
And it's gonna filter out in the other communities.
yeah, basically it was, yeah, so my understanding is, Mike Kane talked to, Representative Moyle, and he said that it was gonna be pulled back and revised, so I'm not sure exactly what that'll look like, so, yeah, we'll probably hear about it by next Tuesday. He'll provide an update.
Is it that the bill where elected officials can be held liable or civilly liable up to $50,000 for not following state law?
That's it.
Yes, that's it. That's it.
Yeah, I'll have to look at my insurance coverage, so.
So, anyway, folks, I'm really sorry to bring those issues that I just think are tragic.
What about food establishment fees?
Mr. Chairman, yes, so that's something we've talked about as well. I've been on the board.
Annually.
Yeah, annually forever, so it essentially the Idaho Association of Counties, which was great, they kind of took that on as far as unfunded state mandates, and that's one that's partially funded through the fee set in Idaho code. But there was no senator or representative willing to take it on, and I think it kind of tied in with public health and, you know, sort of the feelings that are still held from the COVID days. So, yeah, so it looks like that's not going, there's nothing going to be introduced this legislative session. And there is one on solid waste. It was, or is, House Bill 555.
Yeah.
So must have been our August board meeting is when you all authorized me to go to DEQ and say, we're not going to continue to do non-municipal solid waste. Our interest was the private facilities, not transfer stations, county owned. But the director of DEQ just determined it'd be kind of all or nothing. But now, this bill will take the public health districts completely out of solid waste, and it's passed the House and the Senate. So essentially on July 1, the implementation date correct, unless the governor vetoes it, which he won't, then all the public health districts will be completely out of the solid waste business. So we don't generate any revenue as a cost, but we've certainly done it for a lot of years. We're required to do municipal solid waste, so we weren't able to, you know, opt out of that, but we'll be out of the business completely. So that's, you know, just basically the counties will be working with DEQ unless DEQ decides to, like, the only way we would be involved is if they chose to contract with us. It's kind of what we do for the public water systems. It's their responsibility. They contract with us because we have staff all over the state. We as in the 7 health districts. So there may be some discussion opportunities for the board. Probably by, I don't know, the May board meeting, we're going to meet with Director Byrne. We as in the district directors at one of our upcoming meetings and say, hey, what are you thinking you're going to do? Are you going to hire the staff and do it yourself? Or are you planning to look to the districts to possibly contract?
He was the one that testified at IAB, wasn't he?
Director Byrne, yeah.
Yeah. And basically said, we don't have the resources to do it.
Yeah, and then this year, the Idaho Solid Waste Association, they were in support of it, making this change just to have it be consistent, the consistent regulatory oversight. But yeah.
But Mike Kane and Russ have worked tirelessly, and Kelly Brassfield from IAC has been on some of our calls. And one of the most disheartening things to me, and maybe it's an opportunity, was the attitude towards the public health districts in the legislature. We are not viewed in a positive light. Do you care to elaborate on that?
I mean, I think that's true. I think that's like when you ask about the food fees, it would seem to make sense that you'd want the users, people who are benefiting from their business, and we do inspections to be able to have them pay the cost and not necessarily the taxpayers, because that's where it comes from, is the county revenue is what covers about 60% of the cost of doing that program, but it's kind of like, don't touch it because it's a local public health district issue so I think that's kind of indicative of what the environment is.
Yeah.
Yeah, like.
So hopefully next meeting, folks, I can bring you more positive news, because we do continue to meet each week. But I'm stunned.
So when the executive council seats comes up, May of 2027, you guys will be.
Yeah.
Able to arm wrestle over who gets to do it.
Yeah. But thank you for your tireless involvement.
Yeah.
And Mike's just been right there.
Yeah, I love policy work. I think it's really important. It's hard. It's hard work I think about all the bills that Betty Ann just described. There's
more.
Yeah. There's nothing that I could see that would actually positively impact public health. It's all, and that's how I've found we seem to be in more of a defensive mode. The Parents' Rights Act revision, I think, is absolutely critical to get it done sooner rather than later. Coming up on 2 years since that went into effect, and Senate Pro Tem Kelly Anthony, he's supportive. We met with him, and he's from like down in the district public health district 5 Twin Falls area. He heard a lot from his medical providers, and he said, I get it needs to be changed, but it's the held up in the House, and that person who's proposing the child care bill that we talked about is the same one who wants to kind of hold the ground on the law as it is. So, but she got called out in a KTVB article, so I don't know if there'll be any activity to try to revive that before the session ends or not, but hopefully so.
It's just tragic. I mean, a kid can't pick up a phone and ask for help when the parent is probably the one that's abusing him. So anyway.
Any other thoughts?
Nicole, you really look perplexed.
No, I'm pondering the West Nile thing actually,
Oh,
because, horses regularly get ivermectin. And West Nile virus, the transporter at the cellular level is inhibited by ivermectin. So even though the virus can bind, it can't get to the cell and infect. So yeah, I was pondering putting ivermectin in birdseed to save the birds too. No, but just having a carve out some of those legislative pieces where, there's protection for the child to have access. I understand the spirit of what they want to do, but at the same time, there are those emergent, and there's always exceptions to the rule. There's got to be a way to protect those kids and give them, because to translate that into some gender thing doesn't make sense. Especially from, the mental health struggles that generation's going through. I concur with you. So there's got to be a way to put language in there that would carve out and protect those kids. Yeah, I am perplexed by a lot.
well,
That's why I'm looking perplexed.
Yeah, this Kratom thing isn't done yet, and it is an industry bill, and they're only interested in money.
Mhm.
So,
Well, next item is the director's report. Russ, here.
Okay, so all I have is we're meeting in 3 weeks on March 20th because of the move this date back a week. And at that meeting, I'll be bringing a proposal as far as ideas for our budget for fiscal year 27. The two big components would be what we ask for as far as the county contribution, and then also salary increases or pay plan for our staff, since that's a huge, personnel is a huge portion of our budget. And I did get Gary, but our HR program manager reached out and received all the information from our 4 counties. And I don't know if you remember last year, I was able to present that to you, just so you can see what our counties have done as recent as October 2025 for their staff. And so that'll be part of the consideration, but I'll have that to share with you then. So that's the only update I have. Very good. Thank you, Russ.
All right, well, we're almost ready to wind this down. Today, we're kind of doing a trial run of this open discussion idea. I sent out an email. If y'all had a chance to peek through it, did any of the board members have something that they wanted to, that struck them, that they wanted to discuss that has come up?
Well, I'm enthused about what has happened to the food here pyramid. And I do hear a lot of general public discussion, which I think is good. That's really good.
Well, and that was one of my suggested items. I think that's personally has been long overdue. We've had some industry-driven nutritional guidelines that have affected, school lunches and things like that. They've not necessarily been actually science-driven, and I think this revision brings us a lot closer to, real human health. And ironically, the vast majority of things that affect human health are lifestyle and nutrition issues. And so I had out our WIC flyer in, the foods recommended. And I just wondered, even from some of the staff, and how that new inverted pyramid is affecting the conversations we're having clinically, or if we're going to be emphasizing some of the newer thought processes. Anybody?
Unfortunately, WIC is not able to change what's available at this point to families and moms and the babies. It's all based on the federal guidelines of what we can distribute or what their cards of benefits are for. So we may see something down the road that changes the guidance and what's available, but at this point, we don't have any changes.
Okay. But in personal conversations clinically, are we in a position where we can maybe de-emphasize, let's say, the grains, or shift the conversations more towards the top of the new pyramid? I realize that at some level, what they can buy is restricted, but clinically, are we able to have revised conversations?
I would need to check with our dietitians about how that has impacted the conversations and what type of things the families are bringing to them in questions during that. So I could either potentially have one of them maybe come to a future meeting, or I could provide you like a written statement afterwards. How it's impacting them.
Well, I just would be interested to see if there's any way we can, if it's permissible, to implement some of the new nutritional thought processes. Curtis.
Yeah, Mr. Chair, I'll just share briefly from a health policy and promotion standpoint what our team is doing. One of the really great endeavors that we've been working with is in Elmore County with a housing complex called Falcons Landing. We're working with them to develop a food pantry that will emphasize the new food pyramid. One of the things in particular that we're working to do is we've used some of our trustee benefit funding to help purchase a commercial refrigerator that they will keep on site. And then we're working with them to develop an agreement with an entity called the Rolling Tomato, which will bring in fruits and vegetables that have been discarded by grocery stores typically, and make like a weekly delivery to this commercial kitchen setup, commercial refrigerator setup for residents of this facility to have access to the fruits and vegetables that have been discarded by the grocery store. So that's one emphasis that we're working on and trying to bring to the community is the availability of fresh fruits and vegetables.
Real food.
Yeah.
And I think that they are doing instructional like cooking lessons as well. Like this is the food that's available. We'll show you what you can use with it. So I think that's really cool. Maybe it happens.
Absolutely. Back to our Cooking Matters classes, that is something our new nutrition expert is going to be diving into. It's something that our health education specialist, Alex, has been heavily involved in, offering the class in both English and Spanish of saying like, these are the fresh fruits and vegetables and the things that are available to you locally. This is what you have access to. Let me teach you how to prepare, cook, and consume these in a healthy way. So.
Very good. Anybody else have thoughts on new food pyramid?
Step in the right direction.
Cooking and food prep is kind of a good segue into one other thing. Is an example that I put on the list was an article that was posted a couple of days ago, and they found 90% of prostate cancer tumors had microplastics in it. And in the article, they talked about how routine it is to find plastic in other tissues of the body. And so, for instance, if we're doing a lot of microwaving in plastic containers, we're driving those ions, these plastics. A lot of the food prep and our water sources are getting contaminated with plastics. Just yesterday, I think it was, I saw a video of this floating machine that's out with buoys trying to scoop up the floating mats of plastic in the ocean. And so sea life and birds are showing up with plastic, microplastics in it. And I think given the ubiquitous nature of plastic in our lifestyle, addressing those sorts of things. And if we're having cooking classes talking about, cooking with glass or stainless steel or, things that are less toxic, those conversations that maybe if we're really focusing on public health, we can start incorporating some of the science. I don't know what Dr. Cole, as a pathologist, thinks about an article like that.
Eat your broccoli. The reason being there's a chemical in broccoli, sulforaphane, which will bind microplastics in the gut, so you can't absorb them. Or you can take a sulforaphane supplement, and that's actually one of the best chelators or binders of plastics. But yeah, I mean, microplastics are ubiquitous. Average American has about a credit card's worth of plastic in their body every year. And we're exposed. I mean, just even think of your saran wrap rubbing your meat that you buy in the grocery store. It's food touching plastic with a different pH. Water bottles, multiple billions of parts of floating plastic in a plastic water bottle. So it is a ubiquitous thing. It's hard to change once society gets into patterns. There are ways to avoid it. I agree. Glass, metal, cast iron, don't cook in plastic for sure. Never microwave in plastic. But also know that there are healthy foods, whole foods that don't need plastic for.
I look at our hospital industry and whether it would be without plastic. You look at, oh, wow, they're a huge consumer of plastic.
Oh, yeah.
Big time. I can see the food industry switching a lot easier like in the healthcare.
Yeah, like waxed papers and things like that. Like we used to do. The big one.
Well, one of the other topics that I had written down or put in there was the 988 call. But I think we covered that article about that teen, that Idaho teen where they ended the call. I think we hashed that one out pretty good already. Any other ideas? Any other subjects that to cover?
I want to touch real quick on, the news and the hyperpoliticization of public health, unfortunately, and the demonization of people that are trying to do good things. By confession, I'm friends with Secretary Kennedy, so don't hate me, don't love me. Way, I know he's trying to do good things to change and improve the health. And I think, what we see from the media versus what the actualities are. I was just in Washington 2 weeks ago, are far different. So I think keeping an open mind as to the longer term goals, like the food guide pyramid, I think that's a huge step in the right direction. The concept of taking vaccines away from people, no, it's making them available, but individual options, things like that. For example, like the measles outbreak, you hear it every day in the news right now, measles outbreak, measles outbreak. Well, measles is a disease of childhood. It used to be. And unless you're a hyper vulnerable person, it's a febrile illness that you get through and do fine. There are treatments, therapies, especially vitamin A. We are going back to food. We're deficient in vitamin A. We're all absolutely deficient in vitamin D. You guys have heard me say it 1,000 times. And flu and cold season always corresponds with the lower serum levels of vitamin D. I ran a lab for decades, I know. And then on top of that, you'll hear about, say, measles deaths in Texas. Well, I spoke with the experts in both those cases. Neither of those children died from measles. They died from what's known as medical misadventure. They were mismanaged by clinicians, given wrong antibiotics, died from bacterial pneumonia. And the hospital will be liable in both those cases. Those kids didn't die from measles. So everything you read front page and the newspaper, if you have medical or mechanistic or physiologic or pathology questions, feel free to ask me, because I look at a bunch of the stuff that's going around. And this is what my point being is that what degrades the trust in public health. When I look at what Curtis is doing and his team, public health is critically important. The most important doctor that saved humanity is not a doctor, it was a plumber. And sanitation and what we did to improve basically the hygiene of our environment is what's made most of these chronic illnesses go away. Measles was gone before the vaccines ever rolled out. They're turn of the century, there were 300 to 400 children a year that would die from measles. By 1963, when the measles vaccine rolled out, there were only a handful of deaths per year before the vaccine ever hit the market. And it was public health, sanitation, plumbing, food safety, healthier access to foods, overcoming some of the malnutrition we had societally. Now we're exceedingly nourished, unfortunately, but not good things. So shifting that is important. So I think, the frustration you guys are experiencing with the legislature, a lot of that has been a pushback on public health because of, some of the last several years of, I think, overbearing public health from the government federally, which translated to state levels. But if you look at the good things that public health does, that's where we need to, I think, regain the image of the important things that public health actually does. And I guess that's my 20 cents worth.
Well, I don't think we should be afraid to ask questions
Amen.
No.
in science. And the reality of it is that things haven't been particularly successful in the last 50, 75 years in health. We're not really seeing any reduction in heart disease, cancer, diabetes. In fact, not only are we not seeing an efficacy such that we're seeing less of it, we're actually seeing exponentially more of it. The fastest growing population of type 2 diabetics are adolescents now. And so maybe it's time to take a step back and reevaluate the approach to things. And I think Dr. Cole was alluding to demonization of individuals that are actually recognizing those sorts of things and then asking questions probably is highly inappropriate if we're really concerned about what's going to make a difference. And I'm encouraged by things like, something that you would think is pretty common sense is eat real food. And now we're having a national emphasis on something like that. And I wonder where that's been for the last 30 to 50 years as we ramped into more and more processed on real food. When you can't pronounce the ingredient list, you probably shouldn't be eating it.
I mean, and another public health deficit is the lack of emphasis on getting outside. Sunshine, nature, just, the basics of health are so antithetical to our Western lifestyle now. 80 to 90% of Americans spend the daylight hours indoors. So our circadian rhythms are off, our hormones are off. We do have a pesticide problem that I'm highly concerned about. I'm giving a lecture on that next month.
If I may interrupt,
Please.
are we going to tackle glyphosate?
Oh, boy, the one, here's what most people don't know. I love to. Glyphosate, yes, it's an herbicide. It was also a pipe cleaner. It was patented by Monsanto in 2010 on top of its original patents as an antibiotic. It kills your good gut bacteria in your microbiome, which your microbiome is basically the training ground of your immune system. You kill off your good bacteria, you don't get the signals for your immune system to function properly. Now, low vitamin D levels do that as well. So now you have a double hit. You have low vitamin D, and then probably the most important gut bacteria you have is called bifidobacteria. And the higher your bifido levels, the higher your D levels, the lower the cancer rates. Plain and simple. And so glyphosate kills fungi, kills parasites, kills bacteria, but it kills the good bacteria. 87 out of 100 children in the US have glyphosate in their urine. And we're predominantly using it to dry the wheat, the oat fields. Oats are the highest in glyphosate. And yeah, basically almost every American is getting an antibiotic without informed consent every day in their food. And it's shifting the gut health and the immune health of the nation. And glyphosate should. European nations that have banned it have better health outcomes. Most people aren't allergic to gluten. They're getting dysbiosis when they eat American breads. And I don't know if you saw, Dr. Latipo was here last week. Got to chat with him. He's the Surgeon General of Florida. They did a study. Number one, they did a study on candy. Most of the children's candies, the popular ones, were highly concentrated with arsenic and lead. But then they tested 8 major bread brands, and 5 out of the 8 breads had glyphosate above acceptable levels in them. And so glyphosate, I could give a whole hour lecture on it.
Yes.
I won't, but I agree. And then here's the problem. Our food supply and our farmers have become so dependent upon it that quote executive order that said, no, it's necessary. But I can understand the argument that it's necessary until we transition away from it. I don't agree. I think we should wipe it out altogether.
All of the subsidies.
Yeah.
All of the subsidies.
Full of money. Yeah. Yeah. And Bayer's just basically, the gist of it is they have 20,000 lawsuits against them from buying Monsanto, and they're just trying to settle that. And that's why they've gone state to state to try to get liability protection like the 1986 Vaccine Act. basically, no matter what, you can't sue us. And I think one needs to be very aware of what you're spraying in your yard, what your neighbors are spraying, et cetera. And Roundup now has, what is it, diquat in it instead of glyphosate, and that's even more toxic than Roundup. So they rebranded here in the US and got rid of glyphosate in their product, still sell their Roundup brand, but put a more toxic chemical in it. So, and then the endocrine disruptors, don't get me going on atrazine and all the others that are.
We won't even let our cattle eat off Roundup ready cornfields.
Yeah.
As pasture. We will not,
It'll
because
not.
it translates into the meat, into meat.
Yeah, absolutely.
Yeah.
And cattle eating corn converts from omega-3 fatty acid to omega-6 fatty
Yeah,
acid.
yeah, remember, you hear the saying, you are what you eat. That is wrong. You are what you ate. And all life is a sponge or a straw, and you're sticking your straw into a sponge that stuck its straw into a sponge. So you're upcycling from the environment into your tissues. It goes to the great emission, fat soluble, staying in the body a long time. Same thing with a lot of these chemicals. If you eat something that ate something bad, or ate something that it wasn't supposed to eat, then it bioaccumulates in us over time. So it's a mess.
It is.
It is, because
It
the other side of it is we need to really be careful about attacking our American farmers and ranchers and their practices.
Absolutely.
We do. We do.
Because we keep losing
I'm a
ag ground at a alarming rate. And a lot of it is because of topics like this. Can we improve? Yes, but do we need to be very careful about putting the rhetoric out there that our farmers and ranchers are poisoning our people?
Yeah.
Yes.
You look at the disaster, and Treasure Valley is my number one example, what we have done. You better start getting an appetite for concrete and asphalt.
Yep. Whole construct of a victory garden went away. I mean, everybody should have a garden. And if you've got an acre, you should have an animal. Yeah, we need a healthier food supply. And I agree with you 1,000% because I do livestock and organic farming. Yeah,
And a lot of those breads that we're found to have glyphosate were organic, so.
I know. There's no federal standard for glyphosate in organic food. That's another caveat emptor, buyer beware.
And can we feed our populace without it?
Question.
Because we're taking our good productive soils out.
Well, and 90%, of these chemicals, 90% of them are made in China, and on average, 99%. So the majority of these toxic chemicals are coming from overseas. So, going back to farming and ranching, just regenerative farming, hopefully in the future, working with the soil. The fewer chemical inputs, the healthier we will be.
Well, we're coming up on 10:30, but I would, unless the board has any other comments, I would, Doctor, if you had any thoughts on conversation or nutrition aspects, or if you'd like to weigh in, I certainly allow that.
I mean, I can weigh in, but I thought it was interesting your framing of public health deficiencies, because I hadn't thought about it that way, because I feel like public health is up against huge industries. We got Facebook, social media, like these companies make so much money and they're so good at marketing. And then we have the subsidies with food, those in ag industry. So I feel like we're up against these heavy hitters that have lots of money, marketing. So I don't see it as like public health deficiencies, because I think we're trying to do like all the areas. It's just like maybe our messaging is not great. We don't have the funding or the resources. So I feel like, it's not like public health deficiencies. It's more we're up against like industries here, and they know, that's social media is huge, like Facebook, and it's causing our kids to have suicidal thoughts, and they're not good. I think that was just an interesting perspective that I hadn't thought about.
Yeah, and I don't mean public health is deficient. Its image is, and all the good things that public health has, I think, basically tooting public health's own horn and saying, look, here are the great accomplishments. You know, you go to a third world country and you see sewage running in the streets and down the river. It's like, oh, then you look at that our nation, like, oh, we don't have to deal with that. So it's, you know, what we have accomplished, I think it's, yeah, I mean, messaging is important.
I agree. Right. Well, there isn't anything else. It looks like we're wrapped up. Meeting adjourned. See you next time. March 20th, yes. Next month.
Thank you.
Yeah.